All right, in this one, we are going to talk about a super duper high yield topic for USMLE Step 1 and Step 2. This is postpartum hemorrhage. Um, there will be a decent portion of OBGYN questions on both our lectures, and postpartum hemorrhage is probably at the top of your list, right, for things you're going to want to know. So definitely pay attention. This will be a relatively short one, but we're going to cover a lot of topics. So my objective is to talk about what is postpartum hemorrhage, what are the most common causes, how do we medically manage it, what's the deal with oxytocin, what's the mechanism of action of the drugs we use in the medical management, and what are some contraindications, what are the hemodynamic parameters of hemorrhagic shock. We'll talk about Sheehan syndrome, and then we'll do a final practice question. So if you were able to look at my Instagram post from earlier today, or if you weren't, here's the question that kind of stimulated this discussion. So we have a 32-year-old G2P2 woman presents an L&D unit with postpartum hemorrhage following a vaginal delivery. She delivered a healthy baby boy 30 minutes ago. The placenta was delivered intact, but she has since experienced significant vaginal bleeding. On exam, her uterus is found to be soft and boggy, consistent with uterine atony. Initial management with uterine massage has been performed, but bleeding persists. Administration of which of the following is the next best step? And we have a hormone made from the anterior pituitary, the hypothalamus, posterior pituitary, zona fasciculata, zona glomerulosa, or zona reticularis. Okay, so take a second, think about if you can figure out what the answer would be. Pause your screen. So on this one, it's going to be a hormone made from the hypothalamus, and we'll talk about why after we get some of the background info, because the background info is going to kind of set up and leave us a nice framework to understand why this is the right answer. So first, we need to understand what is postpartum hemorrhage. So postpartum hemorrhage is defined as a cumulative blood loss of 1,000 milliliters or more, and it's associated with signs or symptoms of hypovolemia, and it doesn't matter the route of delivery, vaginal, C-section, okay? And it occurs within 24 hours after birth, okay? So that's primary postpartum hemorrhage, 1,000 milliliters of blood loss, doesn't matter the route of delivery, within 24 hours of delivery. Secondary postpartum hemorrhage occurs within 24 hours to 12 weeks. Really, we're concerned about primary, okay? There was this old definition that you might still see in books and other resources where they called it 500 milliliters after vaginal delivery and 1,000 after C-section. That's no longer a thing. It's 1,000 milliliters regardless of route of delivery, okay? So again, postpartum hemorrhage, 1,000 milliliters of blood loss, regardless of delivery within 24 hours, that's primary, 24 hours to 12 weeks postpartum, secondary. So what are the most common causes? This is what they're gonna ask you on step 1. And then it's obviously really important to still understand for step 2, but it's our 4 T's. Uterine atony, so low tone. Okay, so that's the first T. This occurs in about, this is like 70%, right? So if you're going to see postpartum hemorrhage, it's going to be due to uterine atony likely. There's trauma, so lacerations, uterine rupture, hematomas. This is about like 20% of patients. There's retained tissue, like so the retained placenta or clots, 10 to 16%, and thrombin, so certain coagulation disorders. That's only about 3%. So again, the 4 major causes of postpartum hemorrhage are the 4 T's: uterine atony, trauma, retained tissue, and thrombin. Again, uterine atony is going to be the most common cause, okay? So like a classic step 1 question would be if a patient has postpartum hemorrhage, and they'll just ask you what's the most likely cause. You're going to say uterine atony unless they point you towards some sort of laceration or retained tissue or coagulation disorder, okay? So how do we approach postpartum hemorrhage? First things first, we do a rapid assessment, right? We're going to start IV access, and we're going to start them resuscitated with crystalloids, right? IV lactated ringers or IV 0.9% normal saline, isotonic solutions, start that volume resuscitation, and then we're going to try to identify the cause. Once we do that, right, then we go to the treatment, okay? So first line, we're going to do the bimanual uterine massage. So we're going to try to massage the uterus, which will then allow it, that massage kind of stimulates it to contract. Sometimes that's enough, but sometimes it's not, right? So we'll often also start oxytocin. Okay, we can get that IV or intramuscular, and that would be the right answer for our question. And we'll kind of talk about why, like on the next slide. Second line, so you tried bimanual massage, you tried oxytocin, and they're still bleeding. We can go to methyl ergonovine, we can go to carbaprost, we can go to misoprostol, and we can go to tranexamic acid or TXA, okay? So I'll tell you, with regards to these drugs, methylorganavine, it's going to be contraindicated if the patient has hypertension, really important. Carbapenem, it's going to be contraindicated if the patient has asthma, really important. Misoprostol, not really any contraindications. And tranexamic acid, we're going to talk about a little bit more on a further slide. Okay, so let's say we have a patient with postpartum hemorrhage. Again, that's 1,000 milliliters of blood loss, regardless of delivery. Within 24 hours, we're in primary postpartum hemorrhage. We gave them IV fluids. We did a bimanual uterine massage. We gave them oxytocin. That didn't work. So we started up some or a lot of these drugs, these second line, still didn't work, right? So if the bleeding persists, then we go to mechanical, trying to stop it mechanically. So we can do an intrauterine balloon, or we can do compression sutures. These are called our B-Lynch sutures. And if that doesn't work right, we can consider surgery. We can do artery ligation, embolization, and actually a full-on hysterectomy, take the uterus out, right? That's our last resort if nothing's working. So then just remember, I was just reminding you of other causes. So again, patient with postpartum hemorrhage, we start IV fluids. We try to identify the cause. We go to a bimanual uterine massage plus oxytocin. If those don't work, we go to our second lines. We think about methylorganavine, carbapenem, misoprostol, and TXA. If all of those were still bleeding, we can think about intrauterine balloon. We can think about compression sutures, and then ultimately, we may have to do artery ligation, embolization, or an actual hysterectomy. All right. Really important to understand that schema right there, the way we work through it. Okay. And I'll just say one more thing is like, because on step 2, when they ask about management, man, they could stop at any point in this and then say, what's the next best step? So you could start with IV access, and then that's all they tell you in the vignette. They'll ask the next best step. You should pick the thing that says bimanual massage plus or minus oxytocin. If they tell you that they did bimanual massage but no oxytocin, then you say oxytocin. If you did this, then you pick one of your second line, right? Make sure when they ask you a question like that and you're stuck between picking one of the second line drugs, look for contraindications, right? Make sure the patient doesn't have hypertension or asthma, because that rules out these drugs. Okay. If they give you this and the patient's still bleeding, well, then you pick balloon, or you pick compression sutures, or you pick hysterectomy, right? Easy as that. All right. Understand that workup. Screenshot this, practice it. So oxytocin. So this is going to be our answer for our question, and we'll kind of understand why. Okay. So when we go back to our question, right? She had uterine atony. The initial management with the uterine massage has been performed, but the bleeding persists. Literally what I just told you. Next step is to give oxytocin. So now, knowing that the right answer was a hormone made from the hypothalamus, let's dig into oxytocin a bit. So oxytocin comes from the supraoptic and paraventricular nuclei of the hypothalamus. It's stored and released from the posterior pituitary. So if you watch my hyponatremia lecture, I talked about oxytocin and ADH. Made in the hypothalamus, supraoptic paraventricular nucleus, travels to the posterior pituitary where it sits and waits to be released. The trigger for release in oxytocin, mainly it's triggered by labor and delivery, okay? That's one of the main triggers. The mechanism of action, how does oxytocin actually work to reduce the postpartum hemorrhage? It binds to GPCR oxytocin receptors on the uterine myometrial cells. This activates intracellular signaling that increases calcium and induces uterine contractions, okay? The contractions compress the uterine blood vessels, and the oxytocin also stimulates prostaglandin synthesis, which causes further contractions, okay? So overall, it promotes hemostasis at the placental site, and it's our first line uterine tonic. So again, made in the supraoptic paraventricular nuclei of the hypothalamus, travels to the posterior pituitary, labor and delivery, it gets released. It'll bind to GPCR receptors on the uterine myometrial cell, causes an intracellular signaling cascade, increases calcium. The calcium causes uterine contraction. The contraction constricts the blood vessels in the uterus, which decreases blood loss. The oxytocin also stimulates prostaglandin synthesis, which further enhances contractions. So again, that's why our answer for the question was, what drug do we give, right? Or where's that hormone made? That hormone's made in the hypothalamus. It's not made in the posterior pituitary. It sits in the posterior pituitary, but it's made from the hypothalamus, right? So some of our other agents, we'll just kind of expand on these. TXA, it's an antifibrinolytic. It inhibits plasminogen getting converted to plasmin. So plasminogen gets converted to plasmin by TPA, tissue plasminogen activator. Plasmin's job is to then cut up fibrin. Okay, so now we've given them a drug that blocks TPA, so we're not able to convert plasminogen to plasmin, so the fibrin clot stays, right? That's going to help us continue to clot, okay, which is really important in these patients with postpartum hemorrhage. Some contraindications: hypersensitivity. If the patient has a history of thrombosis or hypercoagulable states, we might want to avoid this, okay? Um, Adverse effects: it can cause headache, nausea, diarrhea. Methylorganovine is an alpha-1 adrenergic and serotonin receptor agonist. Both of those going to cause constriction. Okay, so sustained contraction and vasoconstriction. It's contraindicated really in hypertension, obviously preeclampsia, eclampsia, and then COD, CAD, or stroke. They're going to classically give you a patient with hypertension on your exam and ask which drug should we not give, or they'll make you pick between methylorganovine and carboprose, and you're like, hey, those are both good second-line options, but the patient has underlying hypertension, so don't pick methylorganovine, right? That's going to make it worse. So we need to be careful if the patient has a renal hepatic impairment, and then adverse effects obviously can cause hypertension, nausea, chest pain. And then there's carboprose. So this is a prostaglandin F2 alpha analog, and it causes strong myometrial contraction. Remember, I told you on the previous slide, prostaglandins cause contraction of the uterus. This is contraindicated in asthma because it can cause bronchoconstriction, obviously very bad. It can have some CV, hepatic, or renal problems, so watch out in patients with those, and they can cause nausea, vomiting, diarrhea. So again, TXA blocks plasminogen to plasmin. It helps stabilize our fibrin clot. Look out for patients with hypercoagulable states. Methylorganovine is an alpha-1 and serotonin agonist. It's going to cause sustained constriction of our blood vessels. Look out in patients with hypertension. And then carboprose, it's a prostaglandin F2 alpha analog, causes strong myometrial contraction. Watch out in patients with asthma. Classic questions. So, because we're talking about hemorrhage, let's talk about hemorrhagic shock real quick. When I think about shock type questions, they always ask me about certain parameters. They're classically CVP, PCWP, cardiac output, and systemic vascular resistance. So let's talk about what happens in hemorrhagic shock. In hemorrhagic shock, I'm losing blood, okay? So there's less blood flow through my system, okay? So the central venous pressure, which is usually, we can tell by like the JVD, right? What's going into my jugular veins, what's going into my IVC, SVC, we can measure it that way. That central venous pressure is going to be decreased, reflecting the reduced preload, right? There's less blood flow in the system, less blood flow going back to the right side of the heart. Thus, the central venous pressure is decreased, okay? The pulmonary capillary wedge pressure is kind of like a pseudo pressure of the left atrium. So whenever you see PCWP, just think left atrial pressure, okay? This is going to be decreased because there's a reduced left-sided preload. So if there's less blood going to the right side of the heart, there's going to be less blood going to the left side of the heart, and then there's less left atrial stretch. So the PCWP decreases. Cardiac output will try to be maintained initially, or it'll be increased by compensatory tachycardia. But as the shock progresses, it'll decrease. So remembering, cardiac output is heart rate times stroke volume. In these patients, stroke volume's way low because we have a lack of blood. So the heart rate's going to compensate, right? You'll see their blood pressure's like 80/40, but their heart rate's like 150, right? To try to compensate to keep that cardiac output up. Your heart can only do that for so long until it can't, okay? So cardiac output will likely be low if they give you a patient who's been in hemorrhagic shock for a while, right? Okay. Systemic vascular resistance will be increased due to compensatory vasoconstriction in early shock, but as the shock continues, it may decrease and that systemic vascular resistance will decrease. So remember, when there's a lack of forward flow to the kidneys, my JG cells will secrete renin. That'll kick off the whole renin-angiotensin system. That'll cause some constriction of vessels, some holding on to sodium and water, try to get that systemic vascular resistance up. Decreased blood flow through my baroreceptors, my carotid baroreceptors. If there's decreased flow through that, there's decreased signaling to my nucleus tractus solitarius and decreased signaling downward back through my body via the vagus nerve. And remember, the vagus nerve is my parasympathetic nervous system stimulator, right? So if there's less flow through my carotid baroreceptors, there's less signal for the vagus nerve, right? And that dampens down my parasympathetic nervous system, allowing my sympathetic nervous system to take over, right? So they're usually in balance, sympathetic, parasympathetic. We've dampened the parasympathetic. So by default, the sympathetic's winning. We constrict vessels. So the right answer in a patient with like hemorrhagic shock, you would say the CVP is low, the PCWP is low, the cardiac output will likely be low because they'll give you a patient like further on, and the systemic vascular resistance should be high, like until it can't be anymore. Okay, so that's usually the right answer on exams. Obviously, they can give you patients at like different presentations, so make sure you're really reading and thinking through the clinical problem. But at the end of the day, hemorrhagic shock is a lack of blood flow, so then think through these parameters appropriately. Okay, this lecture would not be complete if we didn't talk about Sheehan syndrome. Okay, classic question for step 1 and step 2. So what is Sheehan syndrome? It's caused by ischemic necrosis of the pituitary gland after severe postpartum hemorrhage. So what happens is during pregnancy, we have really high estrogen levels. It stimulates your pituitary to enlarge, okay? When the pituitary enlarges, unfortunately, the vessels supplying it usually don't enlarge too. Classically, the posterior pituitary has a beautiful blood vessel supply, but the anterior pituitary is relatively sparing. So as the pituitary gets bigger, the posterior pituitary is able to be perfused appropriately. The anterior pituitary is kind of hanging on for its life. So any kind of hemorrhagic problem or loss of blood supply is going to greatly impact the anterior pituitary, but not so much the posterior pituitary. So then you get a patient with postpartum hemorrhage who loses a lot of blood. There's a lack of blood flow now to my anterior pituitary, okay? And you can kind of see what's happening, right? We're going to talk about it. So some risk factors, hypotension or shock, if the patient has a small cell turcica where the pituitary sits, vasospasm or thrombosis, or potentially even autoimmune. But really what's going to happen, we're cutting off blood supply to the anterior pituitary. What are my anterior pituitary hormones, right? They're my flat pig. So FSH, right? LH, ACTH, TSH, and then prolactin, and then GHRH, right? So the early clues, right? You're gonna have a patient who just gave birth, had a postpartum hemorrhage, and now she's maybe a couple weeks out and she hasn't been able to lactate, right? That's due to a lack of prolactin. Maybe she has secondary amenorrhea, right? She has a lack of GH or GnRH or FSH and LH, right? GnRH comes from the hypothalamus. It's going to try to stimulate the anterior pituitary, but there's no blood supply to the anterior pituitary, so it's not going to be able to make the FSH and LH appropriately. Okay. Other symptoms, we might see fatigue, hypotension, and hyponatremia. If we lose our ACTH, we lose stimulus to the adrenal gland. And now this patient could be presenting kind of similar to adrenal insufficiency. Okay. Remember, the hyponatremia is because cortisol inhibits ADH. We've now lost cortisol. ADH runs free. Go watch my hyponatremia lecture. I explain all that. You could get hypothyroidism. We could progress to full-on adrenal insufficiency. We're really not going to see diabetes insipidus. The posterior pituitary is usually pretty protected. So that would be a story for another day. So again, hormone loss pattern. We classically will see prolactin and growth hormone will be the earliest, most common deficiencies. Then we can progress to gonadotropins, TSH, ACTH. If we do imaging, we might see an empty or partially empty cella. So again, during pregnancy, estrogen increases the size of the pituitary. The blood vessels supply the posterior pituitary really well, but not so much the anterior pituitary. If we get some sort of shock or hypotension for whatever reason, blood supply to my anterior pituitary is not going to be able to keep up, and we can get ischemic necrosis of the anterior pituitary. You're going to show up with a loss of prolactin and growth hormone usually first, so the patient will probably have a lack of lactation, okay? Classic sign. Then they can progress to like secondary amenorrhea because they don't have their GH and LH that's supposed to cycle through or cycle us through the menstrual cycle. Then they can progress to like hypothyroidism, adrenal insufficiency, things like that. So really high yield point, understand Sheehan syndrome for your exams for sure. So let's put it all together. We have a 30-year-old G3P3. She presents to the L&D unit with severe vaginal bleeding 45 minutes after uncomplicated vaginal delivery. The placenta was delivered intact. Her uterus was initially soft and boggy, and she was diagnosed with uterine atony. She received bimanual uterine massage and the following medications in succession. She got intravenous oxytocin, TXA, intramuscular carboprose. They tried a Bakri balloon with minimal improvement in bleeding. Her current blood pressure is 84/50. Her heart rate's 122. Estimated blood loss is now over 1,500. She has received 2 units of packed red blood cells. So what should we do next? So take a second, think about it. You can pause your screen. So in this patient, right, this is like a do or die situation. She's clearly in hemorrhagic shock. Okay. She's lost over 1,500 milliliters of blood. She has likely end organ damage here. She's progressing to that. Her blood pressure is really low. Her heart rate's compensated. We have tried everything we should, right? We did a uterine massage. We did oxytocin. We did TXA. We did carboprose. We even tried the balloon. Nothing's worked. So I told you at that point, we need to now consider like the final step, right? Total abdominal hysterectomy. So taking out the uterus in this case is actually probably going to be our best bet. That's going to stop the bleeding for sure, right? We're going right to the source. So the ACOG, so the American College of OB and GY or of OBGYN, emphasized that hysterectomy is a life-saving procedure and should not be delayed in the setting of ongoing hemorrhage and shock after failure of conservative measures. So we try to do uterine sparing procedures, but they may be considered if the patient is stable. But this patient was extremely unstable, right? 84/50, heart rate of 122. We're going to consider hysterectomy here. So I'll just go back to that slide real quick. Again, we do rapid assessment, IV fluids. We do bimanual massage and oxytocin. We do second line drugs like methylorganavine, watch out in hypertension, carboprose, watch out in asthma, misoprostol, and TXA. If the bleeding persists, we can consider a balloon. We can consider compression sutures. If that doesn't work, right, we can consider ligation and embolization if they're stable. If they're unstable, we're probably going to have to go to hysterectomy. So that's what I was testing you on here. So again, postpartum hemorrhage, super duper high yield topic. Please understand this. Go back through this lecture again. Understand the 4 main reasons. How do we define it? How do we medically manage it, right? What are some contraindications of some of those drugs? What are those hemodynamic parameters in hemorrhagic shock? And then Sheehan syndrome, right? Sheehan syndrome, we're just going to want to look for a patient who can't lactate, who has amenorrhea, who feels fatigue, constipated, slowed down after a postpartum hemorrhage. We should consider Sheehan syndrome. All right. Reach out if you have any questions. Let me know what other topics to cover.